On this episode of the ASC Podcast with John Goehle, we discuss the latest news, review a recent CMS Quality Safety and Oversight memorandum related to a new resource for infection control, discuss post-COVID surgery risks, debrief from the January ASC Administrators Bootcamp, and during our focus segment, we visit with the staff of Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle during our winter retreat.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 179 of the ASC Podcast with John Goehle for January 29th, 2023, recording from our studios in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies and recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
I feel like we've been in the studio for, well, because we have been in the studio for a week. We just finished our January 2023 Administrators Bootcamp, the cohort. Had a lot of fun. It was a great conference. It was 4 days virtual, like all of our administrators boot camps, like all of our boot camps, and we really had a lot of great conversations, discussions, group discussions, and I think we had more speakers this time than usual too, because quite a number of our staff members were able to join us this time.
Yes.
So it was quite fruitful. And we do want to welcome our newest management company to this training. Bravado Health joins Physicians Endoscopy to our ongoing training programs, and we had a great time with all of the people that are joining us from these management companies. So this is becoming a way for management companies to train their staff as they come on board. So if you're interested in more information, certainly reach out to us at info@ascpodcast.com. And Sue, we are celebrating our 5-year anniversary. This is 5 years doing this, just finishing our 5 years. So as we begin our 6th year.
It is hard to believe.
It is hard to believe, yeah. And wow, 179 episodes, and we got a lot of plans this year, as you'll hear when we talk in our focus segment about a recent retreat where we talked a lot about those things. The retreat was great. It seems like a long time ago now, but it was only a couple weeks ago where we kind of, we do this twice a year. We try to do it twice a year where we get together with all of our staff from the two different companies and discuss all the things that are going on and make some plans for the future. So a lot of great things going on that you'll hear during that focus segment. And we have some exciting news. We are announcing, as we've been talking about for, I think it's about 3 years now, our business administrator or business officer boot camp, whatever we decide to call it. It will be announced very shortly. It's going to be similar to our other boot camps. It's going to be 4 days. It will be virtual. It, just like all of our other boot camps, will involve mentoring and access to our patron program as well as the weekly drop-in sessions. We do have the date settled for this. It'll be 4 days starting on Tuesday, August 8th. Stay tuned for more information. We're going to be announcing a whole series of we're going to be announcing all of our boot camps through the end of the year very shortly, and you'll be able to sign up for those boot camps. They have become very popular, and I believe we are over 200 graduates at this point for this. And Sue, I think we have some other exciting news.
Yes, we have been talking about Rosie. She's looking up at me. She's like, are you going to tell them what's going on? It looks like she has probably around 8 puppies that she is expecting. So we're excited about that. That'll be the very beginning of March.
That's right. She's never very far from us. So she's sitting between the two of us in our studio here. So if we ever go virtual or if we ever start recording these podcasts, with video, we'll definitely have an extra microphone for her. But it's an interesting. It's a lot of fun going on right now. Definitely a very interesting time to be in this industry, as well as to own a dog that's pregnant. So, Sue, we have some news. We haven't talked for a bit on news. So why don't you update us on some of the things that are going on?
So on the January 11th MedPage Today, they featured a study published in JAMA about patients' perceptions of clinicians based on the color of the scrubs that they're wearing.
This is fascinating. I love it.
It's an easy fix if you have any issues with trust in your center. Green scrubs were most associated with surgeons, followed by light blue, which makes sense. Black scrubs were ranked most negatively by patients and visitors, but as we know, clinicians sometimes tend to like them because they're a little more flattering than some of the other ones, and they hide the stains.
Right, and I love black. I love black, so it's kind of funny. I guess we better stop wearing it.
Well, I think this is scrubs in particular. Blue scrubs were chosen most frequently as reflecting caring in the person who was wearing them. And the point they're making is that although there are obviously many other more important factors that go into the clinician-patient relationship, this is one thing that could really easily be modified, and it's low cost and pretty simple to do if you're looking at, buying new scrubs for your place. It's something to take into consideration.
And it's kind of sad because I think a lot of us are trying to get away from the traditional green scrubs to make us look a little different from hospitals. But that's an interesting observation.
And the Joint Commission has begun reducing and revising some of its standards to help streamline and reduce the burden on healthcare organizations that have been strained by the pandemic and other issues with staffing and everything. Here's a quote. They said, "Our goal is to eliminate any standard that no longer adds value. We want to have fewer but more meaningful requirements that best support safer, higher quality, and more equitable health outcomes." So for ASCs, they've deleted 20 standards and have revised 1. And you can find the list of retired standards on the Joint Commission website. These changes will be effective as of February 19th, 2023.
I find this interesting, Sue, because I think one of the objections people have sometimes to the Joint Commission is that the ambulatory standards are based upon the hospital standards that were established years ago and the hospital system for running a survey, and sometimes it just doesn't fit neatly into the way an ASC in particular operates. So kudos to Joint Commission for looking into this and perhaps listening to their the organizations that they surveyed and trying to find a way to simplify it, because the more standardized, the more the less complex these standards are, and the easier to read and understand. And removing those that absolutely have no relevance to the ASC setting is a great step. So again, very nice to see that this is a positive action. It's actually nice to see anybody removing standards now
that they feel like
that are not
really that relevant. And they did remove a lot of hospital standards. But they went through each general site and looked at each one, which is good.
And it's clear that the purpose is not to reduce the
quality.
The quality here. It's just to reduce the redundant standards.
Yes.
So.
They've also added a safety briefing as part of the survey process. So this is just a short, maybe 5-minute time allotted at the start of the survey for the organization to brief the surveyors on any potential safety issues and how to respond. These can include workplace violence, active shooter, fire, any other issues pertaining to safety. So they suggest that you make sure you have somebody appointed to kind of review that with them at the beginning. And lastly, the Joint Commission put out their national patient safety goals for ASCs in 2023, and these include, and this is just a very brief run through, they have more details on their site. Correct patient identification, and especially using at least 2 identifiers, as we know, to identify the patient. Medication safety, the main issues seem to be labeling of medications that are in unmarked containers, such as syringes, cups, anything like that. Make sure they're labeled. being extra cautious with any patients that are on blood thinners, and med reconciliation, including thorough medication instructions and the discharge instructions. Preventing infection, focused on hand hygiene, and preventing surgical mistakes, which focused on the site marking, correct patient and site identification, and pausing before the surgery to make sure no mistakes are made. So they didn't specifically, in the condensed version, they didn't specifically say a timeout, but just sort of taking that moment. And I'm sure they require a timeout, but, just taking a moment to be sure you're doing the right thing.
And these aren't dramatic changes in the patient safety goals, but they are important because they do point out ongoing issues that have been identified in healthcare surveys done by Joint Commission over the last year, and those types of things that they find having the most of a negative impact on safety and quality. So it's always good, even if you're not a Joint Commission organization, to know what they're looking at.
I think there's always a lot of crossover. I mean, obviously, these are things that are important to any site with any accreditation organization. And I saw this in the U.S. News from December 15th. According to researchers at Vanderbilt University Medical Center, patients who have had COVID-19 are at a significantly higher risk for postoperative complications. Now, this has been noted in other studies, and I believe we've even talked about it, but they found the time frame is longer than they previously thought. They found that risk was still declining more than a year after the COVID diagnosis. So the risk for cardiovascular problems, including clots, strokes, heart, and kidney damage, dropped from approximately 18% to 10% in the first 100 days and reached about 8% after 400 days or 13 months. They found the rate of decreasing risk was not affected by the patient's vaccination status. So I thought this really is significant enough to warrant being a part of the discussion with your patients when you're scheduling patients, depending obviously on the urgency of the surgery, but it is a piece to take into account.
Yeah, so the longer that you wait after after somebody's had COVID, the better the expected outcome or the less chance of a complication.
And I'm not sure people think about it unless, they're still testing positive or they say, I just had it a month ago. But it's really something to really look back that in the past year or so.
Especially concerning given the number of people that are getting COVID or having COVID again, even after having it before. So this is definitely something you should be thinking about, and certainly not rushing people back into surgery if it's not absolutely necessary.
And probably you've all heard about this, but 25 people in Florida were charged with participation in a wire fraud scheme that sold more than 7,600 nursing degree diplomas from 3 Florida-based nursing schools. They also provided false transcripts to some of these people. The diplomas and transcripts allowed people to sit for the nursing board exam. Some of the people that purchased the fake degrees did have legitimate LPN licenses, but hadn't gone to school for an RN. Honestly, I don't know how someone without the proper education would be able to pass the NCLEX. And to me, that's maybe the craziest part of this. And yet they said 2,400 of the 7,600 students eventually passed the board exam. So federal officials say the people who bought the diplomas may lose their certification, hopefully will, but they phrased it as may, but will most likely not be criminally charged, which I kind of found interesting. I mean, that's
a large number of people, too. 7,600 nursing degrees. I'm kind of shocked at it, though. It made the mainstream media. There's an awful lot of talk about this, so hopefully people will keep a closer eye on it. But it is frightening to think that that's out there, though. As you said, the 2,400 that did pass the NCLEX is not an easy exam.
No, I don't.
Kind of surprised, but and again, it certainly points out the importance of doing all of these background checks on people and keeping up with this. So, as you know, we're always monitoring the quality, safety, and oversight memorandums that come out from CMS. And in January 19th, 2023, this year, there was a QSO-23-06 for all Medicare providers in the nation related to provider and supplier compliance education through Quality in Focus, or QIF trainings. So this is actually really good news. So the background here is that CMS performs over 100,000 compliance surveys of Medicare and Medicaid certified providers and suppliers each year. And to increase compliance with the CMS's health and safety regulations, CMS has used the findings from all of those surveys to inform a series of short, between 10 and 15-minute quality and focus, or QIF, interactive training videos tailored for specific provider types, including ambulatory surgery centers. And the intent of this whole initiative is to provide a resource for providers and suppliers to proactively address common compliance concerns and therefore increase the quality of care for patients and residents. These trainings highlight both specific citation patterns as well as compliance solutions to incorporate into facilities' operational practices. And each interactive video focuses on a specific health or safety citation with the goal of helping facilities proactively identify and prevent these deficiencies in the future. And for the ambulatory surgery industry, the topic is not surprisingly on infection control citations. We're going to include a link to both the QSO as well as the website. So they have developed a website for all of the quality, safety, and education portal training, and there's a catalog of all that information, or all of those videos and other training, as well as this new QIF, or Quality and Focus resource. So the title is Quality and Focus Resources for Addressing Ambulatory Surgical Center Infection Control Citations, Training for Providers. They like to have long names, just like I do in our educational programs. So we'll, again, provide a link directly to not only the training for the infection control QIF, but also for the entire resource for CMS. So these are all free. As I understand it, you can actually get certificates of completion by logging in, though I haven't tried this yet, but it's going to be interesting to see how this works. And watch their website for more information to come. We'll also be putting together more links in our patron program website, which is ASC Central, to make the training a little bit more accessible for everybody. But I find this, especially the short 10 to 15-minute time frame, Sue, is going to be really good for many of you who are doing, in-service training, for example, or something that you can have people do, in those few moments between cases that you might have. So I think this is an exciting new resource. I did listen to one of the training programs without having to log in. And again, this is a free resource directly from CMS. Let's talk a little bit about some recent experiences. We have a new center of ours that was cited for the age of their instruments. So they had instruments that were over 20 years old in some cases. And the instruments were kind of worn down. They didn't have, it was very difficult to read the manufacturer, and therefore they couldn't produce instructions for use for these instruments. So the state surveyors in this situation went in and cited them for this, and the instruments have to be replaced, or I think in some cases they were able to use a microscope to find that information and be able to download the resources. But in some cases, even getting the instructions for use for these very old instruments was difficult. And of course, it does come into question. The surveyors were saying, really, if these instruments are that old, are they safe to continue using at this point? So that's going to be an interesting development there. And again, emphasizes the importance of making sure you have instructions for use for every single instrument, for everything that you have in your organization.
And that you're following it appropriately.
Right. And, I got to be honest, so unfortunately for those of you who are going to be subject to a survey by me in the future, one of those things I'm going to do now is probably pick a random instrument that somebody presents or that I see on a shelf and say, can you produce the instruction for use for this? Because it never really dawned on me to actually test that out as these state surveyors did. So be forewarned if you see me show up on your doorstep that I'll be asking that question now. And they also had an issue with double peel packs, and this has been an ongoing issue. Doubling up on the peel packs has been a common practice all along, but the recent instructions for use for most, if not all, of these peel packs indicates that you should never fold over the inner peel pack. In other words, the inner peel pack should fit right within the outer peel pack in order to be in compliance with the instructions for use. So again,
shouldn't be wrinkled or folded, anything like that. Really.
And the other thing, Sue, is that you need to be able to read all corners of those peel packs to make sure that there was no damage to them. So I thought that was interesting. Again, something I have been noting, especially when I'm doing a survey, to make sure that that they have instructions for use for all the peel packs. But now I'm going to be a little bit more diligent with that. So this is exciting. Sue, during, I think it was the first week in January, the Ambulatory Healthcare Strategies team and the ASC Podcast with John Goehle team, which there's a lot of crossover, actually 100% crossover, got together here at our home in Spencerport, New York, which is also our main location for our studios and and just getting together in a little big conference room we have down here. And we recorded, I think it was about 45-minute interview with all of our staff, or as much of our staff as was willing to talk about various things that are going on, including a lot of topics and expectations for 2023. And we thought it would be interesting to share these observations and what we're planning at AHS as well as the podcast. So we have a lot of big plans this year. We got some interesting conferences that we're going to try to put together here, and we talked about that in quite a bit of depth during this interview. So let's take a short break, and when we come back, we'll have that interview. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So we are at the 2023, I guess we'll call it Winter 2023 retreat for Ambulatory Healthcare Strategies. We tend to have 2 retreats a year. Unfortunately, in 2022, those of you who follow us closely know that we had to cut out one of our retreats because we had a certain litter of puppies, and Rosie graced us with that, but unfortunately, we had to cut one of our retreats out. But here we are in January of 2023. With the crew from Ambulatory Healthcare Strategies. Unfortunately, we are a little bit short on our staff at this point. We've had some challenges during this retreat, and so it'll be a little bit shorter podcast than it normally is. But I wanted to go around the room and kind of talk about some of the hot topics that were discussed during the retreat and some of the things that are really kind of leading edge of our concerns in the ambulatory surgery industry. As I ask questions, I'm going to ask each of you to introduce yourselves so that they know who each of you are. We're going to start with a discussion about life safety, which is without a doubt probably one of those areas that came about in the discussion this week. One of the major issues that we're all facing. So, starting with Alex. Alex, introduce yourself and let's talk about life safety surveys and the hot topics.
I'm Alex Borneman, Director of Operations at AHS.
And I'm Mike D'Ambrosio, a life safety consultant for AHS.
Yeah, so talking about hot topics, in life safety, nothing's hotter right now than the emergency electrical systems, or EES. So those are your emergency power systems, like your generators or your UPS battery system. These are at the forefront of the conversation right now, especially with regards to anything lower than a type 1 emergency electrical system. And the reason for that is there's some movement on the state level, but also the pressure on the federal level from the accrediting organizations has just gotten to be so much greater than it's been in the past. And there's increased focus on the electrical system and more in-depth focus. Surveyors are no longer just taking a quick peek at your electrical panels. They want to see the one-line drawings. They want to really dig in and make sure that everything's wired appropriately.
They want to make sure transfer switches are in place and that the drills are being done and that the logs are being kept for those as well, making sure that the regular evaluations on the center's part of those systems are adequate. And that includes generator checks. That includes making sure the areas are marked and the proper labeling of circuits, et cetera.
Yeah. Now, a lot of this is happening, Alex and Mike, because our surveyors are getting better trained.
Right.
And we've known that some of the accrediting organizations have probably, are stronger in this area than others. But from what we are hearing from the industry, all of the survey organizations in the states are going to be in a position where they are, continuing to ramp up their oversight of the life safety area. Now, when I go into a center and especially when I'm doing a mock survey or I'm visiting a center that we have traditionally done some work with, one of the comments I always hear is, don't worry about that area that you just noted on the life safety side because we're grandfathered. So why don't you talk a little bit about what grandfathering means and whether there are any grandfathers anymore?
Yeah, because this is one of the first things that I do have to talk with on the life safety side for new clients, especially. Don't use the word grandfather. Don't use the word. Well, what was the one that you used earlier, Mike?
Existing.
Existing is the right word, basically. So you're either a new center or you're an existing center, and that comes straight out of the life safety code. But they're exempt, I think, was the word that we were tossing around earlier. And there are exemptions in some cases, but in terms of being an older center, that doesn't grant you any exemptions from the life safety code. You either meet the code or you don't. You might be under a different set of the code because you're existing, but that has its own requirements that you still have to meet.
And Alex, along those lines too, sometimes we hear people say, oh, I've got a waiver for that, but waivers are time limited, right? For the most part.
Most. You do have some categorical waivers that you do need to officially adopt. Things like your power strips, especially in the operating rooms. And again, I like to say that there's about 7 different citations that you can get with a power strip. So even after having that categorical waiver. So it's still a dangerous item in terms of drawing a citation. Obviously there's regulations on it because of the dangers with it, in that it's a safety component as well.
And it's best to really avoid them. But if you do have them, you have to buy a specific type of a power strip, and any of the outlets that are not being used have to be covered at all times.
Right. And it's actually even a little bit more advanced than that.
Yeah.
Because you have to actually look at the amperage rating of the power strip and the amperage rating of everything that's plugged in, and then ensure that nothing else is going to get plugged in there. Like you said, by covering those outlets. But there doesn't need to be an official assessment, not called out that way, but you do need to ensure that and then prove it through the survey.
So Alex, this is a tough thing to keep on top of. And I'm looking at you, and I'm looking at Mike, and I'm looking at, unfortunately, Jim was not able to join us, who is our actually a life safety surveyor with the accreditation organization. And we laughingly refer to all of the people that we work with and that are familiar with life safety as experts. And yet I know you, really every person that I talk to who specializes in life safety cringes when I say you're an expert in that area. Talk a little bit about how difficult it is to stay on top of that.
Right. And as a lot of the surveyors will tell you, they learn something new in every survey. As a consultant in this area, I learn something new in every survey. And of course, what that means is every single review that you go under is going to find new items and should find new items, because these codes are so complex that no one person can be an expert in all of them. And if they say they are, they're probably missing something. But that doesn't mean that there's not a use for life safety consultants and for that matter, your life safety surveyors. There's a real reason, even though that surveyor is going to miss some things, that doesn't mean that the next surveyor that comes behind them is wrong.
And again, I think that's important to remember. They're just a snapshot. The survey is just a snapshot.
Right.
You know, in a brief period of time when they're evaluating a very complex system.
Now, of course, and I do always encourage you to challenge, whether it be a surveyor or a consultant. Definitely want to double check that any items that they bring up, because that helps you to ensure that you know exactly where that code is coming from. But also know that, you know, any one review does not guarantee that a more thorough review in the future doesn't bring to light something new and something problematic.
So what are the consequences of your failure to meet all the requirements of life safety?
Well, at the most base level, of course, you have the plan of correction that you have to put together. Assuming, well, that would go for any of the life safety surveys, because that means that it's a CMS survey. And then if you go up to the standard, up to the condition level, that's what then would cause you to have a resurvey. And that resurvey, if it's done by an accrediting organization, will cost you more money. So there's a monetary component, depending on the surveying organization, that monetary value changes. But even if you're having your state do your life safety survey, you still run the risk, and we haven't seen this in any of our areas, in terms of states, but on the life safety side at least, but there is always a risk of a fine.
Some states allow for a fine, and by the way, just because you've never been fined in the past doesn't mean that they won't exert a fine in the future, especially with, let's face it, you know, with the financial situations in many of the states. This could be another potential revenue source.
Yeah, it's a fundraising activity sometimes.
And we're not talking small fines, you know, often these are 5-6 figure fines that can come out. So it is important that you even though you might not have a fine right now, that is the danger of, that is a possibility.
Right. So it's important to note that there's definite risks on both sides, whether you're having your accreditation organization do your surveying or your state.
Risk assessments, Mike, have been a big issue lately. I mean, I will tell you, back when I was an administrator, 17 years ago or such, we actually, I don't even remember that there being a risk assessment. I believe that the NFPA 99 risk assessment has always been there, but it was one of those things that was done by your architect, before you started construction, and we as administrators never saw it. Talk a little bit about you are practically full-time doing risk assessments lately.
And again, regulations continue to evolve. So, the part of the requirements is to have a hazard vulnerability analysis done. And those are critical to identify those areas that need improvement. That's why they're instituted. On the, and it's important on these risk assessments to remember to get a narrative, the kind of description of a summary of the risk assessment to see, what areas were identified as needing improvement. And as well as making sure that there was a final determination documented somewhere, in that risk assessment to show final.
Let's emphasize that again. It's just filling out the risk assessment is not enough. And I know Lori's not here to talk about infection control risk assessment. Same thing happens with that for infection control, hazard vulnerability analysis, fire,
NFPA
99, all of those require not only the risk assessment being performed, but an analysis and reporting the results of that to the quality improvement committee and then onto the board.
Right. In having that final determination noted, I've been in conversations with surveyors before where they say, okay, great, your wet dry risk assessment, which was created by ASCI, says you may have a dry location, but that's not a final determination. That just says you might have a dry location. So we need to determine, okay, yes, we have a dry location. And then now what is that? So there's some centers that have dry ORs that still install line isolation on it. And, that is totally acceptable, but you need to have that actually written out, that narrative and that final.
And again, documented.
Right.
To your point, Alex. But on the HVAs, one of the things we're seeing is, remember, they should be done yearly because you're going to find that things tend to rise up in importance. They become more of a problem, and things change. Whether it's contaminated water, we're seeing a lot of water main breaks, et cetera. That tends to, increase your vulnerability to that particular hazard. So it's important to have those reviewed on a yearly basis.
Well, thank you very much for, we have a lot more to talk about life safety, but certainly life safety is one of those things that's included in all of the retainers of Ambulatory Healthcare Strategies. And if you do need some assistance in life safety, feel free to give us a call. We would be glad to talk to you about this. It's probably one of the more difficult areas right now. And we'll talk a little bit later about some things we're going to do with the podcast too, to help out in this area. I want to move on to finance and introduce Tony Lyons first, and then Zach. Go ahead, Tony.
Hi, my name is Tony Lyons, and I'm an MBA and CPA, and I've known John Goehle for a long time. John, not to blow him in, but he's actually an expert finance guy himself, and so he's great to have over my shoulder. Should I get into some of the things?
Yeah, I want to introduce Zach, who is heads up our cost report division, which is not applicable for all states, but Zach is very much involved in finances too. Go ahead, Zach.
Yeah, hi, I'm Zach Kelleritis. I'm a financial consultant for Ambulatory Healthcare Strategies. And yeah, as John mentioned, I focus on cost reports for our New York State-based clients and helping them with that.
And financial statements as well.
Financial statements and HICRA reporting.
So, Tony, when we last spoke, last time we did a podcast from one of our retreats last year, I believe it was, we talked about how we were implementing a new financial service here, which is kind of funny because we started out this company in 2009 as doing a lot of finances. And then we kind of veered away from it. And then you came on board about
just over a year.
Is it really?
Mm-hmm.
Came on board and we realized that there was a huge need for that. And indeed, after our discussion last year, you had a couple projects working with some of our clients. One is ongoing, one is finished. So talk a little bit about some of the things that are happening in the industry and why all of a sudden are we starting to find a need again for financial oversight services?
Well, I think, first of all, the whole accounting financial realm, in healthcare, it speaks to the business side of our organizations. And accounting is the language of business, no matter which business you're in. So that language has to articulate the condition of a company to a number of different audiences, to the government, through, out of the financial statements and cost reports, as Zach mentioned, and other reporting, some of the loans and things we've received in the industry for because for COVID relief,
right.
Requires reporting on our financial position to the government. So then, of course, there's banks and financial institutions, because if you want to get any loans, if you want to get any, anything to start up or to keep going, you need to have adequate financial information.
As well as the possibility of selling your whole organization in the future, or buying out a partner, or having a new partner buying into your organization.
Exactly. And that's the next audience, ownership. The current owners, they want to know where we're at. If you're going to sell it, you really need to have your financial house in order. So you can sell an organization without having your financial house in order, but you may short yourself if you don't know what you've got. And then a really important audience, because it has a direct impact on the operations, is management. And management needs good information in order to react. And it's interesting, this year we're doing financial statements for 3 organizations. Zach does it for an organization in Ohio, and I did it for one of our organizations here in New York State. And now I'm doing another one. The 2 here in New York, and I'm not real sure about maybe the one in Ohio also. These are not new or young organizations, they've gone through a life cycle.
Yeah.
And what often happens is, a center can be successful for a number of years and maybe get into a rut. And even with your financial reporting, it gets slack. It's lax. Then when things are changing in the industry, whether it's COVID or whether it's physicians retiring out, in the industry or with your own center, if you don't have good financial information, then you're really at a loss for reacting quickly enough to. You can't change the conditions just by having financial information, but you often don't know the conditions until it's way past the time you should have started making changes.
Yeah.
So we're finding it's organizations, and I'm sure younger organizations too, but that are far along in their life cycle that you would think would have this down pretty well. But because of turnovers in our centers, in not only with nurses but also in the business office and with finance people, you bring in finance people that are not familiar with the healthcare industry. It's an education to start to understand the things you really need to be paying attention to. We're heavy on the personnel side. The whole materials management is a different area. And then there is accounts receivable. The revenue generation process is it is different than anything else from all sides. I'm not an expert on coding and all of that type of thing, but one thing we've helped centers do is to help them understand where their receivables really are, what their agings are, and how they compare to other organizations. Actually, accounting and finance overall is a standardized mechanism that helps the government, banks, owners, everyone to understand how their organization compares to others and how it compares to their past experience. So it's information that needs to be done well, needs to be done timely, and often that process falls by the wayside because there's so many important. I've run ambulatory surgery centers, and there's so many important things to take care of, and it's one of the things that can get neglected either by ownership or management or both, and needs to be revived. So we've had the opportunity to do that for a couple of organizations. We're working on one right now that's we're making some progress on, and I think it's really something that could be helpful to a lot of ASCs.
And isn't it fair to say that, like the two projects that you've worked on in the last year, both of them, when the money was flowing, and they were making plenty of money, and there was distributions going out, nobody was questioning. Nobody was spending a lot of time looking at the accounts receivable, because they didn't feel like it was an issue. By the way, there's a good chance that even at those times, there was an accounts receivable issue. It's just that you were making enough money that you weren't worried about. Your abundance was masking problems that were there. And would eventually catch up with them. And in both of these circumstances, they ended up coming to us almost too late for us to be able to solve their problem. I mean, in one case, we're still working on it, but it's a lot more work to do it after the fact. And isn't it true that in both of these circumstances we've had in the last year, that when they came to us, our biggest challenge in the beginning was that they were all on a cash basis of accounting?
Well, that's right. Yeah. So we have been able to help them be on an accrual basis, which is, again, with the standardization that helps you understand where you're at in the industry and to have a better idea of matching revenues generated in the period by the activity in that period with the expenses of that period. Because if you're on a cash basis, you're not doing your accruals, and you're not either on the revenue side nor on the expense side. So, and then having, I think non-accountants often think of the income statement, but the balance sheet is very important. And to produce adequate balance sheets, you need to have good accrual income statement information on an ongoing basis. So, and then that whole area of looking at accounts receivable is so important in any business, but in healthcare, it is very, very important. So, yeah.
So not only is there this realistic need for financial information in order to be able to run your business, keep yourself profitable, identify a situation where you might not be profitable moving forward, but there's also a regulatory component.
Well, that's right. Yeah. In terms of, in many states, but here in New York State, is all centers are required to get audited financial statements because we need to do cost reports, which we do quite a volume of those. Zach is the main lead on that, and I work with him, and that's a requirement. So, along with other requirements that are required of other industries, just tax reporting, payroll tax reporting, and there are companies that get behind in those things, and you cannot afford to do that because of the penalties that will occur.
And most recently, the PRF reporting, the Provider Relief Fund.
That's right. And,
which is not ended.
Yeah. And then, it's not an area we get into, but I referred to it earlier in terms of the actual billing and the coding and that type of thing. That's a whole compliance area that is very sensitive to, that in hospitals I work with quite closely, and that needs a lot of attention. Yeah. So and another area, this of course is only for newer centers or centers that are adding services that you need to get a certificate of need for. The way we start a certificate of need project is by doing a feasibility study. Yeah. And that becomes, of course, a base document for the owners, as well as to submit to the approving authorities. Right. So it's that's another regulatory, your governmental look-see.
And Zach, on your side, you've been, Zach, of all of our employees, probably has the biggest challenge with deadlines, because whereas I think from a compliance standpoint with surveys, we actually have the ability to kind of predict within some reasonable time frame when a deadline is going to come. Unfortunately, with many of these, like the Provider Relief Fund deadlines, which was a moving target, the cost report deadlines in New York is a moving target. And the various extension you get for various things, as well as new things. In Ohio, we have reporting for, I forget, a tax assessment. I'm blanking on the name of that tax assessment out there that has to be done on a regular basis. Alex, let's finish up by talking just a little bit about provider relief funding, because I believe that we have some more deadlines still to come in the future. Some of them are in the past, but we want to remind people of the importance of getting those reports in on time.
Yeah, and one of the upcoming ones is for the payments that will be in reporting period 4, which is the next one coming up. And that would be payments received between July 1st, 2021 through December 31st, 2021. Available, basically the last day to use that money was the end of this past year, so December 31st, 2022. And then the reporting time period opened 5 days ago, and it goes until March 31st.
Okay, and moving on, let's transition to Jenna. Jenna, you have been very, very busy this last year. Jenna kind of heads up our startups, and we thought we would talk a little bit about what's our experiences with startups, both for those of you that are listening that are thinking about starting a surgery center, or many of you who are already in the process of starting a surgery center. Talk a little about the challenges that you've had recently with that in today's environment. First of all, introduce yourself.
Okay. Jenna Alvarez Sr. We never determined whether or not we were changing our title. So I guess we're sticking with the old one.
We're sticking with the old titles for now, yeah. We're having an identity crisis in the company.
My startup specialist, secret title.
We don't put that on your cards.
That's because I have 1,000 at home that I refuse to get rid of. So we've had 3 projects that have been like in full swing, under construction in the past year.
We had a number that are fully up and running now. I can't remember how many.
2 of them are up and running. One of them I'm literally refreshing, email every 2 minutes, waiting.
You're getting a little obsessed about that, so,
waiting for the plan of correction results to come in. So we're a little messed up with the holidays as to when exactly I'm getting it. So you always have your normal delays in the project. I mean, I think the project that opened in April, we thought was going to open in December. The project that we opened in March, we thought was going to open in January.
Lesson number 1, no matter what you think your deadline opening date is going to be, it's never
project that we thought we were going to be opening this week we thought we were opening a year ago,
Yeah, I mean, I think it's an important point if you're building a new ASC right now or about to build a new ASC in the next, say 6 months, it'll take you 18 months to get a generator. So start planning for that now.
Yeah, and we're not joking. And the generator has been one of the major challenges right now.
And equipment in general.
Yeah.
I know, some of the sterilization equipment is at least 8 months, and that's one of the new challenges. Usually it used to always be like the construction delay, or, you ran into something, you had to change something.
Well, and I have a real concern about that because as I'm looking at Donna, we all know one of the things that breaks down all the time in our surgery centers and is sterilizers, for example. Absolutely. And, getting the sterilizer, one of our critical pieces of equipment breaks down and we have to wait 8 months for a new one or try to find a reconditioned one. That could be a very frightening situation.
So if one of yours is coming up to end of life, start looking.
Yeah, very good point. Very good point. Sorry.
And then the other challenges that we've had that I feel like have been, well, maybe not new, but more prevalent this time around have been, we've had a number of centers that have lost key people before they even opened, either a nurse manager or administrator, which really then, my one center, I'd worked putting the policy manual together with the first nurse manager. She left. Then we had a new nurse manager come in and we kind of had to start from scratch. I mean, we had the policy manual built, but it's a new person who's going to be running the center, and she might want to run things a little bit differently. It's
different experience levels and right.
And honestly, going through the policy manual was it just brought up a lot of conversations of, oh, what do you mean by that, Jenna? Oh, well, okay, let's talk about, your what you're doing for pharmacy, your hazardous drug, like what type of hazardous drugs are you using, or are you using hazardous drugs? So many different things. That the policy manual kind of prompts questions as we're going through kind of our template to say, okay, we need to personalize this to you. Mm-hmm. And it's a lot of things. There's so many things that you have to decide starting a center. It kind of has been nice this time around. That's kind of been my starting point of, okay, let's talk about this. That I don't know. I think I've had a lot more involvement this time, which has been nice. Sometimes I have centers that just are like, okay, give me a policy manual.
Yeah.
And then we find out that the centers aren't following their policy manual, and it's not.
They think they can just buy one and then just implement it. It's not the case.
And that was where you run into problems. And I think it's been really, it's center to center is so different. And I've definitely worked with a lot of great nurse managers in the past, but then again, I've had people leave, and then I have a whole new, you have a whole new group of people coming in that, what worked for the first nurse manager doesn't work for the second nurse manager.
So one of the other challenges I think you face, Jenna, too, is that those that have been operating surgery centers for a long period of time, or those that have been through a survey, or those that have studied, the regulatory requirements, they're well aware of what's going on and what is needed. But it is not infrequent that these owners who have developed the surgery center, who hired somebody to come in and do it, are shocked at the magnitude of regulatory requirements that are out there and the risks that they as an organization are taking when they set up a surgery center. Talk just briefly about some of those things that you've run into recently.
Yeah, well, I think some surgeons who haven't, have worked from the hospital before, but never in a surgery center. Or maybe they do work in a bigger surgery center, but now they're starting their own smaller surgery center. And
they hadn't been exposed to the whole thing.
They're one of 4 surgeons.
Yeah.
They don't realize, I can't remember who I was talking to. I've got a number of startups, but I've also got a number of my centers that are preparing for their 3-year reaccreditation. And so one of my administrators was telling me that she was talking to her surgeons, and they had said, well, they're not going to want to talk to me. And she had to come back and say, you're one of 4 surgeons. If they come the day that you're the surgeon operating, they're going to be following you around a lot.
Right. You better be prepared.
It's not you're one of hundreds of of physicians in a hospital, and they maybe spend 5 minutes in an OR compared to the rest of the So it is a little bit different. And then the other thing that I've been trying to really emphasize this time around is for these centers, as hard as that first survey is, your initial accreditation, especially since, if you get one condition level citation, you fail.
Right.
And you have to, reapply. That second
will probably be the worst survey that you'll ever have.
Because a lot of times on that first survey, you don't have a ton of back data for them to look at. A lot of it is you're promising an awful lot of things, and they're seeing what you have set up. 3 years later, they're coming back and saying, okay, did you actually follow through with all of that?
Right. And they're not prepared for that because they often say, oh, that first survey was a breeze, not going to be a problem. I'll pass this next one. That happens to me all the time when I go in and do a mock survey for an organization that's preparing for the second survey. Oh, don't worry, John. They never saw that the last time. They will this time.
Or they might not this time, but they could 3 years later. It's just because you never was cited on something before doesn't mean that they won't cite you.
That's almost a throwaway that you just said there, Jenna. But that could be like the title of articles or even this podcast here, is that just because you weren't cited before doesn't mean you won't be cited in the future.
And remember, you're not just doing it for a survey, but if something happens, obviously patient care, but also just if something happens, people are going to pick everything apart and look, and you don't want to have anything that they're going to be able to point to and say, things weren't done right.
Yeah, once we identify a problem, then we dig into it even deeper. So.
Well, and they can tell if you haven't been doing things for the past 2.5 years, and then suddenly you clean everything up in the last 6 months.
Yeah, us surveyors are kind of smart. Right, Ann? I have Ann Geyer also on it. We're not dumb people, and when we're
we
going
know what to look for. We know where all the secrets are.
That's right. Thank you, Jenna. Moving on, I'm going to introduce Judy. Usually I introduce Judy to talk about her role with our educational program. But Judy this year took on a new role, and that is she does some of our does medical record consulting also for our clients. And New York, one of the reasons for that is New York State requires you to have a medical record consultant. I believe that's the only state that has that requirement. But I thought, Judy, this time I'd have you talk a little bit about documentation challenges that we have. Your experience in going in and looking at these charts. Sometimes even the nursing chart audits, everybody just looks at the same things. Everything's fine. I, as a surveyor, come in 100% compliance, no problems with the nursing chart. And I come in and I just trash chapter 6 in case of AAAC. Talk about some of the things that you've been seeing recently and the importance of having somebody. And I'm not saying necessarily a consultant. That's great. And it's a great advantage to have a consultant come in, but even making sure that your nursing chart audits are robust.
My name is Judy D'Ambrosio. I am the director of education, but I'm just jumping now into the medical record field. And I think what I find most interesting is that if you read a center's policy in chapter 6 or medical record, one of the first ones says the center is going to put someone in charge of the accuracy and collectiveness of your medical record. And if I go in and visit and I ask who that is, they look at me like I have 4 hats. I don't know. No, nobody.
Happens to me all the time as a surveyor. Yeah, they don't know who's in charge.
So if no one's in charge, then I already know exactly the things to look for. Nobody's taught these people that this is a legal document.
Yeah. This
is not something you have to do because you're forced to document. This is a legal thing. Mm-hmm. So what you say or what you don't say, what you document or what you don't is really very important. And yes, most of the centers do nursing chart audits, which is usually when one of your, a senior level nurse will look over the charts, a certain number of charts, to see how her nursing staff is documented. And I'm always taken aback by, even in my own centers, the centers that I work with, would say, no, 100% compliance, quarter after quarter after quarter. Yeah, no, there's no way that that's possible. And that's either you are looking at the same things over and over again. If you have a chart, nursing chart audits, and you've used that same chart for 3 years, you've already taught them to correct those. So let's go on and let's go a little farther. Let's see what we can find that we need to work on, because there's always something that you can work on to do better. So I find that those are the kind of things I say when I visit. 1, let's figure out who's in charge. And then let's get this person really, really up to date on what needs to be done and what doesn't. And I know that changes more often than I'd care to, even if we just go down through H&P. So you're all probably very aware that there was a change in H&P for both CMS and accrediting organizations. And it didn't help us. Right?
No.
If anybody's out there celebrating, oh, yay, no H&P, oh, God, you're so wrong.
Well, we actually had I think it was about a 2-hour conversation during our retreat here about the ramifications of this new change, which we'll talk about in some podcasts.
I know. It was intended to reduce paperwork, right, to make things easier. But it's almost as if they've made a complete blind eye to, we need to know the predispositions of these patients. We need to know if the patient is being taken care of in the appropriate setting.
Yeah.
And again, it's like they completely miss patient care for lack of paper.
Yeah.
Which seems ludicrous. And I know that like some centers are just going to go ahead and say, we have this in place. Our doctors are used to it. This is what we're going to do because it's a patient safety issue, not a documentation issue.
And actually that has been our experience is a lot of people, even though the option there is to change the timing of those histories and physicals, they are often going back and just using the same one because it's easier than making all those changes and justifying them for CMS purposes.
Those that are screening, I don't think they're aware of what, okay, so you're not going to do this? Well, you have to do this long list of 11 things that I'll teach you to do.
Yeah.
And I don't think all of them have read all the way through it like you do and like Annabelle. You guys know it meticulously.
Right.
So I think that's just going to be one of many problems, one of many things that we're going to need to look at. So I start with reminding them that medical records is part of patient safety. Those people in the office that are keeping care of your medical records are keeping care of that patient.
Yeah.
And if they need those documents, and that information in there may have to go to a different doctor that's help them with a different thing. And I don't know if that's part of even the people in the office that do work give themselves credit for. You are part of the patient safety process. So I really like to start there with those, which is fine. So Sam would say, there's nobody we don't have anybody in charge. I really want to talk to that person, so let's figure out who did. And I'm learning as I go. There's things that I thought everybody did without fail that is not really.
We don't even ask the question. I see that too. Like we just assumed that was happening, and then we go in and
you're taking it back.
We're taking it back.
Wow, yeah. And then you'll go back and look at the nursing chart audit, and that particular thing isn't even on the things they look.
Yeah.
So yeah, I think we have as a company, and this is for the clients that work with us. We have some work to do to get them up to speed. And then the people at the centers need to make their staff understand how important the documentation is. It isn't just a nuisance. It isn't just to get to the end of the day. What you're writing down is really very important and may, be a legal thing in a courtroom somewhere down the road.
Thank you very much, Judy. I want to call upon 3 of my nurses who are intimately involved in and have been challenged recently with staff turnover issues, staffing issues, education of staff. I mean, we could be talking for weeks on this thing. So I'm going to start with Donna and then Ann and then Kathy. If you would each introduce yourselves, and then we'll start talking about this topic.
I'm Donna Montiel. I am Senior Nurse Consultant for Ambulatory Healthcare Strategies.
Hi, I'm Ann Geyer. I'm Chief Nursing Officer.
Hi, I'm Kathy Fody. I'm also a Senior Nurse Consultant.
So, Donna, I'm going to start with you, and of course, I'll let the other 2, and anybody actually wants to chime in on this. Donna, you're our newest employee. Welcome to Ambulatory Healthcare Strategies. I do think you've been on a podcast before, but you came from one of our clients, and we've enjoyed having you here. But is it safe to say that you were thrown into a fire? Yeah.
Well, maybe just the start of a fire, not a big fire, but I think there's a real need in the ASC community now for companies like this. The challenges of running a center are much greater than they were 20 years ago when I started, for
right.
Sure. And this is a whole different side of the business. So it's been interesting.
And to that end, some of the challenges that you've had have been with sudden turnovers in organizations, the organizations that have new, senior leadership in the organizations. And fortunately, they have been wise to call upon experts to be able to help them with it. Not that they are not capable of being able to do this themselves, but they, taking over a new organization, especially when significant change. Often what you've run into is that the entire leadership team has changed. So
right. Yeah, I have a couple of centers now that the entire leadership has changed, and with the new administration coming in, some of the DONs have decided it's not a great mix and have left those centers. And that's a huge challenge because with a new leader at the top and not having a DON or a strong DON to kind of get the message across to all of the staff, they're kind of floundering and trying to find a director of nursing who is not just experienced, but experienced in the world of ASCs is very difficult, very hard to find. And the learning curve for somebody coming in from a hospital or somebody coming up from a staff position can be pretty severe. So this is going to be where we step in and try and mentor these new people coming in or coming up to get them to the point where they can really be independent.
And that's where some of our boot camps, those are not familiar with our services at Ambulatory Healthcare Strategies, as well as the ASC Podcast. We have these boot camps that are 4-day virtual conferences that provide the skills, not all the skills, of course. You can't learn everything by book or by 4-day conference, but they have been very helpful in doing that training. So just talk briefly about some of the things that you do immediately when you go in. What are the first things that you do, when you are brought on to a client that has had this sudden change?
So the first thing for me, and again, because I'm so new at this as well, is trying to just get a gauge from the person who is in charge to say, where are you with all of regulatory compliance? Where are you with your reporting? Where are you with, all of the things that you're monitoring that you should be looking at monthly, quarterly with your life safety stuff? And, what do you have in place already? And where is that gap? I guess sort of the gap analysis to see where you are and where you should be. And then try and get a good idea of the level of understanding and knowledge for everything that needs to be taken care of in a day or a month or a quarter. That's really where I've been starting so far.
And then from there, we identify the resources that are needed, provide, in our situation, we provide those resources and give them the proper training. But I think it's important, to your point, it's important that as soon as this change occurs, if you are the owner of the company, you've got to bring those additional resources in, whether it be from a consulting company, whether it be you as the owners, to step up as quickly as possible, to identify somebody to take charge, and be very careful about bringing people in that do not have expertise in ASCs. That's been one of the challenges that often, owners do not understand, that you can't just pull somebody out of a hospital and throw them into an ASC and expect them to perform at a high level.
Right, very true. And also, to your point, bring somebody in quickly, because once you start to fall behind, you're forever chasing after that, trying to get back to where you should have been.
And Kathy, I'm going to go to you. I'm not sure this is the question that I prepped you for, but we'll let you. We'll help you out in this one. So, Kathy, I'm very concerned about the nursing shortage that we have. I'm going to have Ann talking a bit about where we are in the nursing industry, but it's suffice to say we're having problems finding nurses. And sometimes that challenge in finding nurses means that we either don't have enough nurses to be able to maintain the same level of care, or we have a quality issue, or we have a gap in education or a gap in skills to be able to do that. So can you just talk a little bit about some of the concerns that we have when we go into a center about making sure that that everybody understands that you need time to train, you need time to identify people to come in, and that sometimes that's going to mean that you're going to have to slow down the cases?
Sure. For me, being quality background in Six Sigma, or being black belt, or however you want to deal with quality.
A black belt in quality.
Quality. Yep. So yeah. So basically, we work off, the premise of work better, not harder. Create a lean environment in an ASC. However, if we go too lean, the quality of our patient care is affected. Research has shown that, patient satisfaction goes down, potentially poorer outcomes if we don't have the amount of staff. And I find the challenge, especially in this environment after COVID, one, we're having difficulty finding nurses because you've got a large proportion of nurses who've decided, I'm 55, 60, I've done my career, I'm going to go into something else. And then we have younger nurses that don't necessarily, they have the expertise that may potentially be required in a PACU setting where you need a little bit more critical care, or someone in an operating room, which is more specific. So you really need to have that strong director of nursing. She is your I point everything back to director of nursing. She is the resource for every nurse in that place. And if you have a young staff or a lean staff, that director of nursing is wearing multiple hats, trying to educate, precept, and still meet the requirements, the regulatory requirements to offer the continued quality of care. And to have, you don't want to badmouth your owners, but I think, for them, it's more a business aspect versus, well, we can do these cases. We've got, we can pull the director of nursing, but if that director of nursing is in an operating room and she's not available to answer the questions for others, it's really, really difficult. And it's a hard conversation to have when you are running so lean that you don't have anybody to step in, your per diems to step in if somebody is sick or calls out for a personal reason. It's really, really difficult to run a center on a daily basis.
And there is no excuse for maintaining the same volume of cases that you were doing before because you don't have the finances. Good luck defending yourself in court in that type of a scenario.
Absolutely. Absolutely.
And you're chomping at the bit.
Yeah, I can talk on this for an hour.
So I probably better focus, Ann.
I know. Well, John, I can be very pithy with this one. I'm going to tell most of you that are listening on this call, do not hire the first warm body that interviews with you in order to fill a position because you're afraid you're going to have to staff. Do not do that, because once you've done that and they're not competent or they're not motivated or they don't demonstrate initiative or they're not ASC background, you have made a mistake you're going to dig out of for a year. So, and I can't, in my long career, I've seen that done over and over again where the administrator hires there's been an opening, it's been open for a month. She hires the first nurse that comes down that she even thinks will show up for work, number one, and it's a huge mistake. So that's number one. Number two, always have in mind the worst case scenario that you might lose somebody, a key player, and have other people identified that could move up into that position. And this especially applies to your leaders. That's where you're mentoring, as John will probably say. I'm passionate about mentoring. Identify potential leaders and start training them while you're still there. Something could happen to you. Something could happen to your director of nursing. I totally agree with Kathy that they're the pivotal role in the surgery center regarding clinical operations. But what is your plan? What is your backup in case XYZ happens? Because guess what? We're seeing XYZ happening every single day.
Thank you. We are, as always, we talk a lot and we have these retreats have been very valuable. I want to kind of call it to a close here, though. We are actually calling the whole conference or a whole retreat to a close at the same time that we're calling this podcast to that. But to really kind of point out that we at Ambulatory Healthcare Strategies, we're a very close-knit group, as we've proven yet again here in the last 3 days that we've been together. We're very proud of this company. I've been very proud of what we've been able to accomplish. And we are at your service. We are here to be able to solve any of these problems that we've talked about. So feel free to call me at Ambulatory Healthcare Strategies.
585-594-1167. And we'd be glad to talk about our needs. But Sue, I'm going to end with the two of us and talking a little bit about the podcast and the importance of this free resource. So obviously, you've already discovered it if you're listening to this. In addition to the free podcast, there are other items that we have that are already available, but also things that we've talked about and actually have decided to introduce as a result of our Saturday morning sessions with our patron members, which I encourage you to become a patron member if you're not already, where you can just drop in any Saturday morning at 10 o'clock Eastern Standard to talk things through, as well as have access to a broad database and a number of free conferences that you can listen to. It's a very good value at $25 a month. But the other things that we have is conferences on credentialing. We have our boot camps here. We have the Conditions for Coverage conference. We have infection control training that is available to provide you with a certificate to prove to surveyors that you are that you have the training to be an infection control coordinator. And then during this conference, we've decided to introduce a couple more conferences. We're going to be doing, I can't believe we're going to do this, but we're going to do a 2-day human resources conference sometime within the next 12 months here. I know that I've had a lot of calls during the month of December asking me to be able to help provide people that have the CAS credential with HR credits. So you're going to have an opportunity to get 16 credits, I think, if we do this right. So we'll be announcing that soon. And then a big thing that came out of this is recognizing the importance of life safety. So Alex and I and Mike and Jim Masters, who's not on with us, are putting together some type of a program. We have no details yet because we haven't figured this all out, but we are going to be one of your major providers of life safety consulting moving forward, and I'm very excited about that. Sue, do you have any? It all falls to Sue because, I can come up with all of these ideas, but somebody's got to edit all of these podcasts. Somebody has to, schedule these things. And I just want to publicly state thank you, Sue, for doing that. And thank you. Go ahead.
Just going to say you're welcome. And I know we always go back to this when we first started this, that I couldn't believe we'd be able to come up with more than, maybe 4 or 5. I thought we're going to run out of subjects, but it just more and more keeps coming up. And I think, we're always open to any new ideas, things that people want us to talk about. We really like being a resource and an educational, something you can go to for your staff or yourself and between the boot camps and just listening to the podcast.
178 episodes. I believe this is 179, and we're still going strong. And this January of 2023 is our 5th anniversary of the podcast, by far the longest running podcast in the industry. I want to thank all of you at Ambulatory Healthcare Strategies. I'm actually somewhat teary-eyed coming to an end here because we have had so much time together. I know we're exhausted. We're a little sad. One of our members became sick during the conference, and obviously that's weighing on ourselves right now. We hope she gets better. But I don't want to thank all of you. I want to reach out to all of you that are listening to realize that we're here, either as a free resource. Or our patron program, which is a step up from that, or going all the way to the services of Ambulatory Healthcare Strategies that really, gives you a lot of hand-holding through these difficult times. It is becoming even more important as this industry gets more complicated for services from companies like ours. So with that, I sign off and thank you so much.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So the Georgia Society of Ambulatory Surgery Centers and the South Carolina Ambulatory Surgery Association is getting together for their semi-annual conference and trade show, March 30th and 31st, 2023 at the Renaissance Atlanta Waverly Hotel.
And the AORN Global Surgical Conference and Expo 2023 is April 1st through the 4th at the Henry B. Gonzalez Convention Center in San Antonio, Texas.
And ASCA 2023 Conference and Expo will be May 17th through the 20th at 2023 at the Kentucky International Convention Center in Louisville, Kentucky. So I'm so excited about going back to Kentucky, and we're going to get everybody together again from our as many people as we can get there from Ambulatory Healthcare Strategies and the podcast, and hope to see a lot of our listeners down there. And if we do the same thing we did last year, we'll send an invite out to get together somewhere mutual for all of our podcast listeners, and maybe and do a live interview for the podcast. So definitely keep an eye out for this, and make sure you sign up. I think the tickets are going very quickly for this. Also wanted to talk about our upcoming boot camps. We have not actually, at least when we recorded this, we have not announced officially the dates of all of these, nor is there a link yet. But within the next couple of weeks, we'll have the links for the next 3 boot camps. The May Director of Nursing Boot Camp will be in May 2023. And in July, we will have the next Administrators Boot Camp, the same thing that we just did a week ago. And then, as we announced earlier, in August, we will have the first Business Office Manager Boot Camp. And that date actually has been settled. That would be Tuesday, August 8th through the end of that week. And also don't forget about our pre-recorded events, all available on ASCPodcast.com. We have our 2020 credentialing conference, still very valuable and useful today. In fall 2022, we had a finance and accounting conference, which would be helpful for anybody that's studying for the finance section of the CASC exam. We have our conditions for coverage conference from 2021, which we're going to re-record this year, but that's an 8-hour conference on all of the conditions for coverage for ambulatory surgery centers. We have our medical director conference also from 2021, which helped prepare medical directors for surveys. And of course, we have the on-demand versions of our Director of Nursing and Administrators Boot Camp. And don't forget about our patron member program, also known as ASC Central. It's an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And resources include some of our virtual conferences, links and policies and procedures, forms, example drills, and discounts on services and books, and access to AEU credits. And probably the best part about this, in my view, is those weekly drop-in sessions we have on Saturday mornings. So definitely look into this, and that more information is available at ASCPodcast.com. Membership in this program helps to defray the costs of producing the podcast, including research, staff, travel costs, conferences, equipment costs, and production costs. And as I said, more information, visit ASCPodcast.com. And that's it for this episode of the ASC Podcast with John Goehle. And please spread the word about our podcast. We continue to grow, and we do that because you tell all of your friends and colleagues. And please do us the honor of hitting the subscribe button. The sound editor for this episode, as always, is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Amy Durbano, Lori Rodricks, Kathy Foti, Donna Macchio, Ann Geyer, and Diana Powell. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.